Hello, I'm Dr. Soundram, pediatric endocrinologist at Apollo Children's Hospital, Chennai. So today I'm going to talk about insulin pumps. So what is an insulin pump? So basically there are two types of insulin pump. One is called the tube pump with the tubing, and the other is called the tubeless pump, which doesn't have any tube. So basically what it is it is a device like this. So this is insulin pump, and inside will be the insulin, which will be filled into this syringe like thing, and the insulin will be fitted into the insulin pump, and the insulin will come through the tubing like this. And imagine this to be the body of the part of the body where the insulin pump is attached, this blue thing. And this small thing will be on the child's body, attached on the child's body. And from this white plastic circular patch like thing, underneath this will be a small 4 mm tubing through which the insulin will get delivered into the fat of the child. And the insulin tubing, so I showed you this tubing, so this tubing will be inserted onto the cannula through this place. Okay, so you just attach it like this, so that the insulin from the reservoir will pass through the tube and get attached to the cannula. So the insulin from the insulin pump enters into the fat of the child, which is underneath the skin. So this is basically a insulin pump with tube. So coming on to the tubeless pump, so if you see this, you just have to peel off the papers here and just stick it on the body. So before sticking it on the body, if you see there is an arrow mark here, so you just have to fill in the insulin through this hole in the patch pump. This is called a patch pump or the tubeless pump. So into this arrow mark, near the arrow mark, if you see there is a hole, and through the hole you have to inject the insulin into this, and then remove the plasters. So you just have to remove the plasters and stick it onto the body of the child. And then the cannula, like how we saw this cannula, the cannula is there within the patch itself, so it will get lodged on its own onto the fat of the child. So it is nearly painless. Both the devices, when you insert, mild discomfort only will be there, but the pain is not much. So basically what are we trying to do in this insulin pump? So if you see, there are international recommendations saying that insulin pump is the best form of treatment available currently. Why do we say it is the best form of treatment? It is because in our body always there is some insulin production going on throughout the day, but the quantity of insulin production is not the same throughout. It increases and decreases at various time points in the day, and it is being produced in huge quantities during the meal, because whenever we take any food, the food is converted into glucose in the body, and to keep the sugars always in normal levels, the insulin has to be produced, so that before the glucose surges to high levels, it keeps producing lot of insulin, so that it matches with the rising sugar, and always a normal sugar is maintained in our body even after meals. So by using the insulin pump, we are also matching the food intake, and the various time points the insulin levels are different in the body. So we are trying to match the insulin levels, the varying insulin levels in the body, by adjusting the insulin rate in the insulin pump. Whereas in the conventional treatment, where we use multiple injections throughout the day, we give the children two types of injection. One is called the basal insulin, which will be once a day, and that gives a continuous cover throughout the day. However, we are giving the dose only once, and it gives a fixed level throughout the day. We cannot alter the insulin according to the needs. So when the child requires more insulin, suppose in the early mornings and in the evenings when the sugars are high, we cannot adjust the basal insulin. We can only give the other insulin which we give for the meal bolus, which we called as rapid acting insulin or ultra rapid acting insulin, as extra insulin shots to cover for the high sugars. Whereas in the insulin pump we can keep adjusting the continuous basal insulin rate. We can set a lot of intervals. So if we want from morning 4 to 8 o'clock, we can keep a higher rate, say 0.2 unit per hour. Whereas from 8 to 12 o'clock, 8 a.m. to 12 noon, we can keep it at 0.1 unit per hour. And then from 1 to 4 o'clock we can keep it at 0.075 unit per hour. And in the evening we can again increase it back from 4 to 7 p.m. we can increase it back to 0.2 unit per hour. Like that we can keep adjusting the basal insulin rate according to the requirement of the child. So as I told you, in the basal injections where we give once a day insulin shot, we cannot adjust this. So this basal insulin rate is like mimicking what happens in our body in children and adults without type 1 diabetes. So because this is very physiological, so this is one of the best forms of therapy available currently for type 1 diabetes. And the insulin pump has evolved over the last few decades. So initially this insulin pump was a standalone pump. That means we used to fix the rates, as I told you, like for with the varying intervals of the day, we will keep at different rates and we will set it. And then the child had to check the blood sugar by doing finger stick method, and they can enter the bolus insulin. Bolus insulin means either for the food they will give bolus through the pump, which will be some more compared to the basal rate. So basal rate will be going continuously according to our determined rates, but the bolus insulin will be either a correction bolus or a meal bolus. So we will press like 2 units or 3 units of insulin at one shot, so that it covers for the meal or it covers for the existing high sugars. So this was what was done in the initial decades when the insulin pump was just launched. So they were called as standalone insulin pumps. And this was what was done. And then the next stage evolved where it was called a sensor augmented pump therapy, where the CGMS, that is a continuous glucose monitor, was attached. And so the data from the continuous glucose monitor was used to adjust the insulin rate by the patient at that time point. If the sugar was dropping, the patient can suspend the insulin or can decrease the basal insulin rate at that time. So this was called the sensor augmented pump therapy. So the next stage came, that was called as the low glucose suspend. So in the low glucose suspend, so the pump was receiving the data from the continuous glucose monitor. So if the sugar levels touched 70 milligram per deciliter, then the insulin pump would automatically suspend the basal insulin delivery to the body. And the next stage was called as predictive low glucose suspend. So where the insulin pump was able to predict from the trend of the sugars whether the sugar will drop in the next 30 minutes to less than 70 milligram per deciliter. So if that was the trend, then 30 minutes ahead itself the insulin pump could stop the delivery of insulin. So the next stage was called the closed loop system, or the artificial pancreas, or the automated insulin device, AID, or artificial pancreas, or the closed loop. So this is the current form of therapy. So in the closed loop pump, what happens is that there is a mathematical algorithm which takes inputs from the continuous glucose monitor, and it adjusts the basal insulin rate according to the sugar trend, whether the glucose is increasing in the body or decreasing in the body. Accordingly it will adjust the basal insulin rate so that the sugar is almost near to the target we have set throughout the day. So this is called as the closed loop system. Another word is included called as the hybrid closed loop system, because even with the closed loop system, if we do not enter the meal bolus before eating the meal, even with the closed loop system, the sugar can go up after the meal before the pump starts to correct it by giving small boluses again and again. Only one pump has this ability to give auto correction bolus. The other closed loop pumps can only increase the basal rate to correct the high glucose. So still, if we do not give the meal bolus, these closed loop systems will have high blood sugars after the meal. So that is why the word hybrid closed loop system is used, where hybrid means we still have to enter the meal bolus insulin before eating the meal through the pump itself. So we have to just press the button. You have to calculate, so the pumps have something called the bolus wizard, so through which we have to enter the carbohydrates which the child is going to eat, and it will calculate the insulin which has to be delivered based on the insulin at the insulin on board in the pump at that time. It will calculate on its own if you just enter the carbohydrate for the child. So once that is calculated, you have to press the deliver button, then the meal bolus will be delivered. So this is called the hybrid closed loop system. And there is one pump which also gives auto correction bolus, so it is called as advanced hybrid closed loop system. So in this advanced hybrid closed loop system, it can give auto correction bolus in addition to adjusting the basal rate according to the CGMS trend. So this is how the insulin pump has advanced over the last few decades. So with this advancement in the diabetes technology, the children are able to achieve almost more than 80% time in range. So time in range is the duration throughout the day during which the sugars are maintained between 70 to 180 milligram per deciliter. So according to international recommendations, they say that at least the time and range, that is the duration of the day during which the sugars are between 70 to 180 milligram per deciliter, should be at least 70% of the day. So with this advanced closed loop, the automated insulin device or the artificial pancreas, many children are able to achieve nearly 80 to 90% time and range when they enter the meal bolus before the meal. So the other advantage is that because the time and range increases and the sugar control is so excellent, we may be able to prevent the long-term complications. And the other thing is that when these closed loop systems are started soon after diagnosis, there is something called the metabolic memory or the legacy effect. That means soon after diagnosis, if the sugar control is very good, then this the body has this memory of good sugar control soon after diagnosis, which protects them for nearly like 3 decades later on. Also, the complication rates, they have studied that those children who were well managed soon after diagnosis and the sugars were excellently controlled had a less complication rate future on in life. So this is why the international bodies have been recommending this insulin pump, and more recently the closed loop pump, to be started in all children and youth with type 1 diabetes, especially those children less than 7 years of age. So I will just tell you about the available insulin and insulin devices, and then tell about the benefits and the disadvantages. So I showed you, this is the first one. So this is the Medtronic company. The advanced hybrid closed loop system is called the Medtronic 780G. And so in this, if the child has even total daily dose of 8 units per day, then we will be able to start this device. And the second one is called the CAM Ipsomed pump. So this is the Ipsomed pump. For this, the total daily dose requirement of insulin is just 5 units. So even infants who have very less insulin requirement can be started on this Ipsomed. The other thing is that this is very light also. So the children will feel very comfortable. But the closed loop system has been started in other countries, but it is still not available in India. So we will be expecting this closed loop system to come to India soon. As of now, it works as a standalone pump or a sensor augmented pump therapy. We can use it. This is called the Omnipod patch pump. This is also currently not available in India. Some parents are able to buy it from other countries and use it in India. So coming to the advantages of this insulin pump therapy. So insulin pump therapy, basically I told you that it will decrease the low sugar, that is the hypoglycemia, because it is able to decrease the basal insulin rate, as well as suspend the basal insulin if it is required. Second, it will also prevent the high sugars, because it is increasing the basal insulin rate whenever the blood glucose is rising. so the time in range is increased, hence the complication rate, long term complication rate will be less. And patients who are on this closed loop pump feel they have a better quality of life. They're able to concentrate less on diabetes management and focus more on other things in life, and they feel very satisfied with the treatment. And the nighttime sugar control, when there is no food intake or no activity, the nighttime sugar control is so excellent with the insulin pumps. And during exercise, higher targets can be set, and there are exercise modes in all the pumps which allows higher targets like 110 to 150 mg per dl to be set, and the pump itself will adjust so that it maintains the sugar in that range. And sometimes even if it is if the children are more prone for low sugar, we can suspend for 1 hour duration and then reconnect it back. So these are the advantages with the insulin pump. And more importantly, the insulin reservoir and the tubings have to be changed once in 3 days. So the prick for the child will be like one prick in 3 days, whereas with the multiple daily injections, that will be 4 pricks in 1 day itself. So the number of pricks will be drastically reduced in children who are using the insulin pump. That is another added advantage. So coming on to the disadvantages, so these are all just devices. So we have to give the meal bolus, only then the pump will be able to function to its will be able to function very well, so that the sugars are in excellent control. So the meal bolus is still has to be done by the patient or the carer. So that is one thing. The second thing is all the children with type 1 diabetes have very less insulin production, and in the pump the short acting insulin is what is being supplied continuously in smaller amounts. So if there is a kink in the cannula which is attached to the body, or if there are bubbles in the tubing, or if the tubing gets bent and kinked like this and the insulin is not delivered, or the device is, very rarely may malfunction. So in such situations, if the insulin delivery is suspended, then the child will be prone for something called diabetic ketoacidosis. It is because when the insulin is very less or not produced in the body, and the external insulin is not delivered, then the ketones, which are the acids, may increase in the body and lead to a serious condition called diabetic ketoacidosis. So whenever we are putting any child on insulin pump, we always teach them about high sugar management, that is the hyperglycemia management. So if you see that the sugars are high, we will ask you to give one correction bolus with the pump. But if with the correction bolus also you see that the sugar is not decreasing in the next 1 hour, then it is better. You have to give a correction bolus with the injection, that is the pen, insulin pen, and remove the entire disposable set and insert a new disposable set, the cannula, the tubing and the insulin, so that you're sure that the insulin is being delivered. So the diabetes education is very important when we put on insulin pump. So the management of high sugars, that is hyperglycemia, is very, very important. So once you're very careful about that, then the benefits of the pump are much, much more compared to the drawback of diabetic ketoacidosis. So by having a good education about the use of the insulin pump and how to tackle the high sugars, then you can very well take the insulin pumps and have all the benefits from it. Yeah, thank you.